So that's
Great. Thank you very much, Hunter. So we can open it up for questions.
I have a question, Hunter and other panelists. Points well taken. How would you suggest we do that, Hunter? Your point about going beyond talking to ourselves. What would you suggest be some strategies that we consider trying to adopt?
well, you know, for example, as I recall in Rory's shop, Google is the floor up or the floor down? Okay, see, sandwich bite. No, you're not the baloney. They're the baloney. You know, you know, we need to get up and down those stairs. I mean, for example, we need to talk to some of those, you know, those corporate leaders who can influence the, you know, things. I'm, you know, trying to do that in some of the, one of the companies in Cleveland, multinational, Parker Hannifin, you might have seen news, is, you know, has an exoskeleton, but it's their first venture, you know, into utilizing some of their systems and control mobility technology. So I think we need to let, you know, make those people, you know, aware of what this needs are. I think that we have to, you know, maybe have some forums that are larger than, let's say, ourselves. Somebody remarked earlier that we don't have J&J and, you know, whatever in this room. I think that we may be able, with the right influence, to get them in the room. Okay, you know, and I speak of, you know, and I apologize for, you know, for ignorance that I have in, you know, in this.
Go ahead.
Comment on that. I think we found it more difficult than we expected to engage corporate partners in this effort, especially when we look at the evidence-based healthcare roundtable. There was quite good success in including pharmaceutical corporations, hospital corporations, device manufacturers. But there seemed less interest, thus far at least, in this theme as opposed to general healthcare theme. But we're trying. So if anybody knows of a major corporation, maybe there's one here, there's an arm here, and that we should be in touch with, please do so.
So John, may I just respond? One thing that both of us have been involved in is the NACV. Maybe NACV should have a program on, you know, related to, you know, to this general topic area.
So
am I. Hadn't thought about it.
we have a question here at the table, and then I know there's one over there and one over here.
I'm really intrigued by this concept of, you know, how do we get information out there, and how do we, so I'm thinking, do we have this? So someone mentioned pharmacies, you know, sometimes they're a source of some of this, but do we have, you know, where do you start? Start any one of these places. Walmart pharmacy, start in your library, start in your area agencies on aging, where we'd have a kiosk, and you could, anyone, you know, family member, anyone, when they're not maybe in a crisis, hopefully say, I can no longer swipe my iPhone. I have trouble turning the lights on and off. I have, you know, cannot get up and down the curb in my wheelchair. You know, just simple questions that there would be either an index, or there would be frequently asked questions, or there'd be somebody behind that, the nurse call center that's overloaded. Maybe we need a little different perspective than a nurse call center, somebody who's more in that. But, you know, start somewhere and have that interactive. I would think a public-private partnership. There probably would be an industry saying, hey, I'd like to hear those questions. I'd like to get a sense of what's out there. But I'm sensing that, you know, that is a huge need, and maybe we can think of ways. I'm going to think about how can we apply this in the Department of Veterans Affairs and test this concept out of, you know, about some kiosks to answer questions about mobility and technology, ask questions, and can we be responsive to that?
Does anyone want to respond to that, or should?
Sure. You want? There's still a huge disconnect. You know, a lot of the state systems and funding systems are determined by individual rules, by individual services. And I consider myself up on the upward edge of knowing about what technology is out there. I come to these kind of meetings, gatherings, forums, conferences, and I learn more. There is not a whole lot of outreach from the research end down to the service provision end. There's not a whole lot of outreach in that area of just attending, every state or every service provider has some sort of conference. Technology has gained some influence recently, but there's not, they often go out and are struggling to get a person of Dr. Coughlin's stature to present, to challenge the service providers, to educate them, to challenge the home health care providers that go to a AAA and really sit down and work with them. So they not, and I didn't mean to throw them under the fire there, but that's, I was listening to him speak and I was so impressed with him. I thought, well, geez, I got to get him to speak.
When it comes to stature, he's actually fairly short. So
Well,
let's take a question
sure.
from back there.
My name is David Dring. I come from New York, Self-Help Community Services. And we were a part of the video that Maj was talking about and would bow down to them for their leadership around the use of technology adoption. And as a service provider, we have housing complexes where we are trying to do just what you're talking about, and it is very difficult. From the education perspective, there are a lot of tools that are out there, but yet people don't know when they can need to access it. So we learned things called trigger points. When do you have a problem that you become aware that you need to take action on that information and have that information be there? And I just give one example, which is baby photographs. So there's a whole company that makes a business about taking pictures of babies. It is only available in the maternity wards at hospitals because grandparents come and want to get a picture of their baby. And then they send it out to all sorts of different people. So it is at that moment that service exists, people take advantage of it and then use it, and they have a thriving business. So we're in the business of taking care of people who have problems at different points in their lives. Are we there when they have those problems with the information they need to take action to it? And I think the answer is no. And we need to think about how we can do that. So I just want to say thank you, and we're in New York, and we'd be delighted to test and apply any of these things that you're talking about, and look forward to talking with you all more.
And just a quick point on that. There was a federal initiative related to the Affordable Care Act that was trying to promote an initiative around EHRs, electronic health record. And I understand the complications with it, but their long-term services system and how that moved, that was completely missed in that whole sort of incentive program to encourage long-term, because we need a complete integration. We need a complete integration from the long-term services into the whole EHR model that has to be continuous, and that was missed on a federal basis. And I understand why. It's just complexity, but
I think there were some hands up over here.
Just one comment on who's missing from around the table. If I look around the table, I would say the payers, and not only just Medicare or Medicaid, but also private insurance, long-term care insurance, and we need to think about how we can pay for these systems and for the services that these systems enable.
it's not as bad as it looks, because we have Dr. Meadows here from United Healthcare, and I'm sort of from Aetna, so between the two of those, you've probably got about $150 billion worth of annual payer revenues.
There's a hand over there. Go ahead.
I'm with the Office of the National Coordinator. We mentioned EHRs. I just wanted to kind of speak up. One of the things I just want you to be aware of is we recognize that long-term care and LTSS wasn't included in the incentives, but we do have an initiative through our standards office at ONC that is focused on long-term post-acute care. It's called the Longitudinal Coordination of Care Initiative. And we also anticipate in 2013, CMS will be funding an initiative around LTSS and standards, developing standards around for that community.
Go ahead, Rory.
I have a couple of suggestions. Well, one of them is that as far as getting industry more involved, is to reach out, perhaps to have a joint meeting with the President's Council on Competitiveness. I know this is I mean, I've talked to that group, and so I know that they're interested in this topic as well. And so having a joint meeting would be a good way, and that would also get the President's ear on how, because we are, in healthcare technology, one of the, the leading country, if not the leading country in the development of new healthcare technologies. It's certainly a competitiveness issue. And of course, continuing to reduce healthcare costs for older adults and people with disabilities is a competitive issue as well. And I think you could probably get some traction by working with that group. Another group that you could reach out to is I mean, you have individual consumers on the committee, but AARP and AAPD, the American Association of People with Disabilities, would be another group that you would certainly want. One, because about 70% of assistive technology is paid for out of pocket. So you're talking about the people who are actually paying for it are the people, the older adults and the people with disabilities themselves. And they certainly have a viewpoint on what to buy. And some of this technology we're talking about, they are driving the market because of what they're paying out of pocket. With the baby boomers, I mean, you do see a growth in acceptance in technology and growth in willingness to pay out of pocket. Unfortunately, I mean, there's a slight bump in income of people with disabilities as well. I think largely probably due to the Rehab Act of 1973 and Section 504 making education accessible, which certainly made my life possible to get an education and to have economic independence. And so that's changing the marketplace a little bit as well. So I think those groups are something to reach out. Oh, no, then the third one, since Alan's looking straight at me, is that you're never really going to get technology fully integrated into healthcare unless we change the curricula for OT, PT, speech and language pathology, and neurology, physical medicine, and rehab, really, because OTs, PTs, it's minimum, 6 hours or something like that in their curriculum. Speech and language pathology, it's almost nothing at all on OGCOM and computer access. OT, I think, has maybe 9 or 12 hours required. That's nothing in today's healthcare environment.
Lisa had a question. Is there a question over there as well? Go ahead, Lisa.
Okay, thank you. I wondered if any of you had a comment on the following observation that I have. One of them is that I agree, Rory, that the wheelchair technologies are not as good as they could be, especially with the payment system. But we do have more curb cuts. We do have more opportunities to use wheelchairs out in the community. And Jack was talking about whether, this longer longevity of wheelchairs or shorter longevity because people are using them more. But I'll tell you something. The streets are filled with potholes. The sidewalks are filled with potholes as well. I mean, the infrastructure out there is really aging. The Metroliner train, you can hardly get certain types of wheelchairs onto it because of the way that the thresholds are configured getting into the trains. And so for some of you who are talking about, like, homes might be configured in a way that can allow people with disabilities to live fully within their homes. But do you have any observations about the more public situations, like basic infrastructure, buses, trains, taxis? Roy, it looks like you have some comments on that.
I agree with you. The Access Board is trying to tackle that, but the Access Board has, its budget is probably as small as this committee's budget, right? And so they can't push the agenda very quickly. And other agencies have seemed to be less interested. NIDR has supported some of that through the RERC on accessible transportation, but not so much looking at in universal design. Although they're small too, and if you look in the big picture of America's infrastructure, it's kind of it's a yin and yang, right? You want to make the environment as accessible as possible, and you want to make the technology be able to overcome the environment in some ways as much as possible, because you don't want to pave the entire earth, and then.
Let me just give you an example. Last week I was going to our group's holiday party, and along the Boston Common there was only one side of the road that I could roll on, and there was an entire chunk of brick pavement just missing. I couldn't go over, and so I had to go out in the street, on Charles Street where there was tons of traffic. And so I think that, maybe if I had a scooter that could climb up and down missing bricks, it would work. But I think that, um, this is kind of going slightly beyond healthcare, but it's not in a way. Somebody talked earlier about secondary conditions like depression. If we're not able to get out in the community, that is going to cause people to feel more isolated, to develop the secondary condition of depression, to be anxious and afraid. And so I think all of this has to be part of a piece.
Yeah, I agree. I
Thanks.
mean, community participation should be the ultimate goal, right? And unfortunately, you do live in Boston, which is one of the more challenging cities, not only from its historical and geographical, but your city planners have been, sort of used the historical nature of Boston as a crutch in
Yeah,
many regards.
every brick is a city hall paver, and they each have an individual personality.
So, we're taking two more questions, one from Larry and one from Kelly, and then we'll break for lunch.
Yes, let me ask these experts. I'm hearing that universal design is one frontier that if we're put into new and maybe even existing construction could go a long way to smooth out a lot of the difficulties we faced, even though that politically may be difficult. And I'm hearing that interoperable health records is another frontier that could smooth out a lot of things. If we start doing all those things, what is the evidence that you guys see that quality of life can be improved and the cost issue can be addressed? And maybe Jack, you and Rhonda can speak to this because you pay for a lot of people's health care. What is the real promise of this stuff around quality of life improvement and cost reduction, and how do we make that case if there is a case to be made?
Well, can I answer that in a couple ways? So the housing project that we did, Clark Realty is a private-public partnership with the military. It basically takes the housing allowance as the rent for those houses. So Clark Realty owns those houses. So and the military they have a formula and they have a limit based on the military and what they can spend on post housing. That's another word. That's to keep generals from having mansions built and things like that. But so they had to build those homes within that framework and that structure, and then still, of course, they're a company, so they still have to make a profit off of it as well. And they were able to do that through universal design concepts. So it's much cheaper to make accessible new construction than it is to renovate. And if people just have to understand that that if you want to age if you're going to get older and you'll use these features. If you have children, you'll use these features. If you develop a disability, you'll use these features. And so we need to change our concept. And then, of course, the whole concept of visitability, which unfortunately I didn't hear, which means, can I go to Andy's house and have dinner, and if I need to use the restroom, use the restroom. And so that expands the whole the market for universal design, which certainly does, from a construction architecture, save money, and it saves money in some ways because the longer you can stay, I think you can save $1 billion a year if we delay everybody's entry into a nursing home by 1 month. And
to finish this session, let me answer the question about insurance from my point of view. I think it's important to understand that in the main, the insurers don't care about the cost. They're happy to pass through the cost. If an employer who hires an insurance company, such as United or Aetna, decides that they're willing to pay for $6,000 hearing aids for their beneficiaries, United or Aetna will calculate what the premium will be. We'll tell the employer that's a premium. Charge the premium, collect the money, pay for the hearing aids. Or the $25,000 lower limb prosthesis, as opposed to the $1,500 or $5,000 lower limb prosthesis. It's It's when you decide that we, whoever we are, cannot continue to experience the year-over-year increase in healthcare costs, or that a given employer says, look, healthcare is eating up too much of my budget, I'm not competitive in the marketplace internationally, et cetera, I've got to control my healthcare costs. What can you, insurer, suggest that you wind up with restrictions on things that are covered? But the insurer, per se, is passing through the cost. So, you know, it's really, we don't need insurance reform. We need less expensive technologies. Rhonda,
Thanks.
do you have anything you want to add?
I do, and I think that I would probably say to the question of whether or not all this technology is going to make it more effective, more cost-effective, or more effective, period, in terms of improving an outcome. Some of that is actually sounds intuitively like it should be a logical, quick answer, right? It makes sense. It seems logical. But one of the comments that came through in one of the presentations was that technology alone is not the sole answer. It's not a replacement for the people part. It's not a replacement for the professional part. It has to be part of an integrated plan. And so when I hear all these presentations, I'm so amazed and so awed. But the immediate question that comes after I hear the presentation is, what did we do to assess the actual effectiveness and the outcome on the healthcare? Because as awesome as some of these things are, long term, did they stick with it? Did it improve it for them? Did it make it more coordinated? Did it actually assist the providers of healthcare, physicians, hospitals, whatever? What was the longer term outcome of it? I see amazing things being presented today, but did it last? Was it sustained? And in the end, did it actually improve things, or was it a short term wow that didn't get carried on? So I think the areas that I'm most interested in is the longer term impacts, the longer term effectiveness, the longer term that the patient, consumer, person with disability actually see a real gain in their quality of life, not just the quantity and long term of it.
Thanks. I did promise Kelly one question before we break, so do you want to?
Well, is this on? I don't know that it's a question quite as much, but there is a question, but I did have one comment as well. That is, when it comes to technology, people with disabilities make decisions about technology just like everybody else makes decisions about everything else. Does it have a practical use in their life, right? Not necessarily is it going to be a healthcare issue, but does it have a practical use in their life? Is it affordable? And is the cost benefit enough that I'm going to make the decision to purchase it? That's really how people make these decisions. And then the discussion around the curb cuts and how you get around and how the world has changed, a lot of that had to do with human rights. It wasn't the development of technology per se. It was development of that stuff to address a human rights either legal requirement or a human rights issue that was pushed by the disability community. So when you think about technology, so here's the question. So when you think about technology, where's the human rights perspective? Because that's one thing I don't know that we've
That's
really
a great
talked about.
question, but it sounds like an entire another session. So I think we will end and have lunch. And when do you want everyone back?
Well, we're going to start promptly at 12:47.
Thanks very much,
And
panelists.
just
That was a great
quickly
session.
for logistics, lunch for everybody is in our cafeteria, which is the third floor. You're on your own. Speakers and forum members, there are tickets outside at the desk here for you to use for your lunch.